Welcome to the Explore Global Health podcast. I'm Dr. Rob Murphy, Executive Director of the Havey Institute for Global Health here at Northwestern University Feinberg School of Medicine. Today, we are speaking with two incredible leaders in the field of global pediatric health, Dr. Colleen Fant and Dr. Sahera Fargo. They're co-directors of the new Center for Global Pediatric Health here at the Havey Institute for Global Health. Their center is a joint effort between Northwestern University Feinberg School of Medicine and the Ann and Robert H. Lurie Children's Hospital of Chicago. We are going to discuss their journeys in pediatric global health and the vision that they have for the center now and in the future. Welcome to the show, Colleen and Sahera.
Thank you for having us.
Yeah, thanks for having us.
Can you share what you hope to accomplish in these positions and the vision that you have for the center's impact on global pediatric health? I'm going to start with you, Colleen.
We're super excited for this new center. There's been lots of great activities around pediatric global health and research and education and advocacy at the hospital and kind of throughout the Northwestern system. And based on all this great work, now we have the center to support everything. And hopefully we'll really grow a lot of our partnerships, really deepen our international relationships, and really support trainees and faculty who want to engage in the field.
Yeah, as pediatrician, we focus on the most underserved and vulnerable populations. So it's important for our audience to know children and young adults make up more than 1/3 of the world's population, but they're the ones facing most of the health disparities. So we're really hoping to improve the health of children worldwide. To add as to what Colleen said, really foster partnership and to really leverage the expertise that's already existent here.
Now, a center is a university structure that sets it apart from departments and programs. I would like you to tell me what you started with and when and how it kind of merged into this center. Can you just tell me a little bit about the progress from how you started to being this center?
Probably the backbone of global health at Lurie Children's is really this educational partnership we have with Bugando Medical Center, which is a hospital in Mwanza, Tanzania. And that probably started over a decade ago as this really cool bidirectional educational exchange where the Tanzanian pediatric residents would come to Lurie, our residents would go there. And that just was ongoing every year, just always in existence. And then kind of in addition to that, we had all these other activities really happening in silos. So there's a lot of really fantastic research happening in departments of adolescent medicine and infectious disease. There was a lot of difficulty kind of connecting interested trainees and learners with all the cool stuff happening. So based on this educational partnership, the research that was happening, we started to create a network of folks who were just interested in building a team, building a community, and trying to grow from what we have. Now years later and a couple knocking on some doors, we kind of got our team together and now we've got a lot of good programmatic work and we're excited for the next step.
That's exactly what a center is supposed to do. Sahera, how did you fit into all this?
Yeah, similarly, I'm pretty new to the Northwestern family. I've only been here for about a year and a half. I've had experience mostly in global health research and was co-director of a center at my previous institution and really linked up with Colleen when I first arrived to figure out what was the global health landscape. And as Colleen mentioned, it was just a lot of in silo work. So we started talking, started realizing our expertise were really complementary, and we had a lot of similar ideas for how to create the center. And that's kind of how it came about. I think Colleen did a lot of the groundwork.
Yeah, but having Sahera come on was fantastic because she had all that background experience of doing it so we could really learn and kind of model on some of the best practices.
Both of you have extensive experience in global health. Can you tell me about any experience or something from your past that made you interested in global pediatric health?
I'm French originally. I was born and raised in France and of parents who are immigrants and Indian. So I have this French Indian. So I think when you're born an immigrant in a country, you already kind of have the mix of culture. I grew up traveling to where we come from. And as a resident, I really wanted that, even as a medical student, but not to date ourselves. But at the time of when we were trainees, there really wasn't a formal global health curriculum. You kind of had to create your own path. So for me, that happened with rotations as a student or resident in sub-Saharan Africa at a time when HIV was just really rampant. It was the number one cause of mortality. You couldn't come to sub-Saharan Africa and not see, funerals, lots of deaths. And I realized so many of these deaths were actually in infants and young children under 5. I already had an interest in pediatrics, but To me, that was really kind of the spark in the late 90s, early 2000. And I was fortunate enough that right out of residency, I worked with the Baylor Pediatric AIDS Initiative in different sub-Saharan African countries. And that was it. That was like the path for the rest of my career, really. That was the spark.
Well, considering what's going on these days, you may be called back to duty. If you're reading the recent WHO reports and the analysis that have come out about stopping PEPFAR so quickly, the number of new cases that are projected are really, I mean, it's astronomical that between 770,000 and 4.3 million people are going to get infected with HIV now.
And it's really disheartening because it was always such a pride, I think, for most investigators and practitioners in this field to really realize how far we had come in really such a short time. I'm not that old. And to really remember, just even when I give lectures to the local students, they've never seen any infant really born with HIV. They don't know what PJP pneumonia is or those opportunistic infections that we talk about. It's really a foreign concept to them, fortunately. And so it's disheartening to think how far we've come, but we've done it before and the infrastructure is on the ground. I'm going to try to remain optimistic.
No, I agree with you. I mean, we did it once. We can do it again. We're going to have to do it in a very different way. And it's just so tragic the way it's being done. Colleen, what was the kicker for you?
My journey was a little bit different. I went to college at Northwestern and was kind of one of the first participants in their minor in global health. So very early on, I got that academic background in global health, and we were all reading all the Paul Farmer books and getting really excited about equity in global health and social justice. So that was really kind of what sparked things. And then I actually lived in Ghana for about a year between college and med school working on some adolescent medicine work. And I just loved the challenge of navigating between all the different entities and interests and understanding how different people think and do things and how similar we all are. So then when I did pediatrics, I sort of figured out how I wanted to get global health in there. And I have interestingly decided to never do clinical medicine. I've always felt that I'd be a better doctor here in the US, and I'm probably not the person you want taking care of some of the diseases I don't see very frequently when I'm abroad. In residency, I got the experience to help design a modular curriculum for pediatric emergencies for a residency in Kenya. And I really enjoyed that ability to bring in a little bit of subspecialty training and some expertise that a lot of my colleagues on the ground taking care of children don't have access to. So most kids around the world get care from providers who don't have any pediatric training or advanced or specialty pediatric training. And we have so much of that here at Lurie in the US. I really get inspired with sharing skills and tips and tricks for kind of helping take care of the acutely ill kids and support my colleagues on the ground.
You worked extensively on increasing the accessibility of simulation-based medical education. Can you explain how this approach is transforming healthcare delivery in resource-limited settings?
Yeah, I think simulation is this really cool educational tool that's ubiquitous in most Western medical education or health professional education systems, but hasn't quite permeated the global health professions education sphere. As I mentioned, most kids are cared for by folks who don't have access to advanced pediatric training or the opportunities to kind of get trained in special pediatric skills, acute resuscitation, specific procedures. My thought of what I can bring to the game is really some advanced training in pediatric emergencies. So simulation is this really cool tool where around the world, most folks learn how to practice medicine from the classroom, reading textbooks, and then directly go to the bedside and kind of practicing things on patients. Simulation is this bridge where learners are allowed to kind of practice clinical scenarios, procedures, and get feedback and become really masters at what they're trying to do. And then they get that before taking care of kids. There's pretty good data from other simulation programs like Helping Babies Breathe and the ETAP Plus program that using simulation for pediatric acute care does improve pediatric outcomes. And one super cool experience I just wanted to share, I was working with a pediatric program in Kenya, and we were training the faculty there on simulation, and they had 50 graduating medical students who we trained on neonatal resuscitation with simulation. And all 50 medical students were about to enter practice and graduate and had actually never had a hands-on experience resuscitating a baby. They had seen some, they learned about it, but they hadn't actually had the experience. So now this kind of cohort of 50 is going out into field having successfully resuscitated an infant, at least in simulation. So hopefully saving kids' lives out in the community.
No, that's incredible. Dr. Fargo, your research focuses on complications of HIV in children and youth, both in the U.S. and sub-Saharan Africa. How does your work in infectious diseases intersect with the broader goals of global pediatric health at the center?
Yeah, so I think Colleen and I are really examples of different trajectories that you can take in global health because the work we do is so different. So, our work and our research really focuses at the intersection of infectious disease and non communicable disease. So, as you and I were talking, Rob, like we've made such great strides in HIV and in pediatric HIV, in that now it's becoming a chronic disease for those youth and children with perinatally acquired HIV, and that they're, surviving and thriving, but really having a lot of non-communicable disease much earlier on than their adult counterpart. And a lot of the precursors of, for example, cardiovascular disease really emerged during childhood and adolescent at a time that's really important for prevention and intervention. So that's really what our research focuses on. This is especially important in areas of the world like sub-Saharan Africa because we know there is this youth bulge that's coming up. So for those of you who may not know, the youth bulge is this demographic trend where really those between 15 to 24 will be the majority of the demographic in that part of the world. And it's tremendous opportunities for growth, but also challenges, especially in healthcare. So what I'm hoping is that expertise and what we've done will help kind of push forward global health research and help support junior and senior investigators to really create innovative solutions when we think about the intersection of all of these issues in global health.
The Center for Global Pediatric Health is committed to equity, a very hot term at the present time. Can you discuss how your programs are working toward achieving global pediatric health equity and what changes you face in this effort?
Lots of challenges. So let's talk about maybe what we're hoping to do, right? I mean, I think Colleen really laid it out is building multilateralism and really trying to have local capacity on the ground is important. I work on non-communicable disease, but also in infectious disease like social determinants of health and healthcare disparities are really paramount in resource limited settings. And then how do we prioritize research to improve equity? So we have our work cut out for us. I think both Colleen and I can share some successes that we've had on the ground. And I think the long-term collaborations that we've had with certain countries really speak to that. And we can talk about how we want to tackle these challenges.
Yeah, I think it's always a challenge. I mean, in this day and age, that's a little bit of a hot button word, but if you just go back to what we mean when we talk about equity, it's not equality like the same for everyone. It's really trying to kind of raise ourselves all up to kind of a similar standard. And from the education sphere, some of the work we've been doing, we really focus on equitable bidirectional educational exchanges. So from the get-go, it's been really important at Lurie Children's that not only do our residents get this experience in Western Tanzania, but we've been offering it to all of their graduating pediatric residents every year and kind of funding it for over the last decade. Now their residency's actually grown fantastically, so we can't unfortunately afford everyone now, but we're really committed to that. So even this year we have 7 folks rotating here at Lurie Children's from Tanzania. We actually don't have any Lurie Children's residents going to Tanzania, but we still believe strongly in making an equitable exchange. And I think the other thing we really strive for, and hopefully we're really going to push for with the center is, again, talking about equity, not equality. When we look at funding, when we look at program development, really making sure that the bulk of the funding is spent like locally, and a lot of the support for the program really focuses on spending money on the ground and bringing resources in with us rather than kind of extracting stuff.
Globally, on the American side, we've seen a significant downturn in people, trainees interested in going abroad and spending some time applying for longer term research training grants for a year or 5 years. So we have the different mechanisms. It's not just here at Northwestern, it's really nationwide that for some reason people are a little gun shy right now. Any thoughts from the field that you have about why this is happening and if you think this will be a permanent thing or you think it's temporary?
I think it comes in waves, right? Because, like, maybe Rob, you can even speak to that. But during the AIDS epidemic, it was the same, right? Like, nobody really wanted to travel. Everybody was afraid of HIV and AIDS. We saw similar kind of sentiment during the COVID pandemic while everything was shut down. And so we're picking back up after that. But, I'll give you the example because I work in Uganda. It's tricky now. There was an Ebola outbreak in the fall and we had a couple students on the ground. So it always adds some complexity when you're trying to make sure that your trainees, et cetera, are safe. But I will also say USAID really helped with a lot of the logistics for that on the ground. And so I wonder, it's difficult to be in this situation and to make sure that our colleagues understand that we want to continue to strengthen the relationship with the current stakeholders and funding agencies that want to fund that work. But I think that sentiment kind of trickles down, and it's just a lot of anxiety as to, for us, how do we continue doing that work? And it's hard for our trainees not to also see us having that anxiety. I'm hopeful. Again, I'm being the optimist, but I'm hoping that the balance will sway. And I think now more than ever, it's tremendously important to show our colleagues that we're in this for the long haul, no matter what happens in terms of funding or administration. What we strive for as, clinicians, physicians, researcher hasn't changed.
Let's talk about your big partnership with Bugando Medical Center in Tanzania. This has been going on for a long time, and it's a key part of your work. Can you tell me a little bit more about that? Share any success stories or challenges from this collaboration that highlight the importance of relationships like the one with this center?
Yeah, I was pretty lucky that I did my fellowship training here at Lurie Children's and learned about this partnership kind of just even coming into training, and was incredibly impressed by the commitment of the institution here to this relationship and really building it out. If you look at the numbers, we've taken dozens of the Tanzanian residents and they've rotated here at Lurie Children's over the last couple of years. We have a much bigger residency at Lurie Children's than they do. So our numbers are significantly higher for folks who have rotated over in Bugando in Tanzania, but incredibly high numbers just for the last, decade, 12 years or so. What's really neat about it is it really just was educational. Our residents go there for a month. They are observers. They will do a couple educational sessions. Their residents come here for a month. They are observers, similarly do some educational sessions. And then about 5 or 6 years ago, things kind of shifted and we said, we are committed to each other. We are a partnership. What are some other key priorities? So we started to actually expand our relationship. We went from just the pediatric residency to now the emergency room as well. We've got a lot of programmatic work. We're doing the ped simulation on both the pediatric side and the emergency medicine side. We've gotten some grant funding to do point of care ultrasound training, not just in pediatrics, but in the field of emergency medicine. We've done some trauma work now with some database creation based on some priorities set by the ER. And probably the most impressive thing that's happened out of this relationship is our pediatric cardiology program. So when the head of peds at Bugando said one of their priorities is improving their ability to take care of children with heart disease and improve their ability to diagnose and appropriately refer out, we said, okay, we have some resources that we can complement that and do it. So for the last couple of years, we've been doing echocardiogram or heart ultrasound training with the pediatric residents and faculty there. We actually were able to rope in one of our residents here at Lurie Children's to help design some programmatic work, but we've donated ultrasound machines per their request, and the partnership just continues to grow. So we'll be there in September for the third annual workshop session.
Yeah, no, it's just really fun to see how transferring that technology, especially with the drop in prices with these portable ultrasounds and, really making them available. We did the same thing with the FibroScan, the elastography machine that measures fibrosis in the liver. We bought one for a group in Nigeria. They were doing every HIV infected patient, they were doing FibroScans. And we weren't even doing them here in Chicago and they're doing it there. They had the numbers on everybody. It was really quite incredible. Can either of you or both of you tell me what are the emerging trends and challenges in pediatric care worldwide?
Yeah, I will say one of the ones that we've tried to tackle, and again, it's become harder, is we've actually found that climate change has had a huge impact on the outcomes that we've been interested in. So a lot of our work is focused in Kampala, and a lot of the research in general in sub-Saharan Africa focuses on these really large urban capital cities. And the air pollution is really awful. So what we've tried to do is kind of measure the air quality, both through questionnaires and then also kind of fitting in personal air monitors to some of our participants. And what we found, not surprisingly, is that the particulate matter, the like fine particulate matter that we know is associated with, issues from a cardiovascular and lung health standpoint are really sky high and are associated with a lot of the outcomes that we're interested in measuring, which isn't so novel in that we've had that data, from China and larger cities. But what's really unique is that these kids are only 12 and we're already seeing an impact on their cardiovascular health. So for me, that's going to be a really big thing to tackle for our center, is how climate change is jeopardizing children's future and how that's catalyzed by changes, access to clean water, electricity, all the social determinants of health that we're measuring and that are typically lacking in the groups that we're focused in. And then I'll just say one more, and I'll hand it to Colleen, is that we actually have also found that there's just a lot more internally displaced children worldwide, even in zones that are not conflict ridden. So Uganda is right on the border with South Sudan, and we're just seeing a ton of refugees coming in. So I think, how do we continue to protect these children? And that number will continue to grow. So I think those two are the ones that are really going to be big emerging trends and things that we'll have to tackle.
I think from the academic side, many, many countries around the world have really elevated their national hospitals and the amount of subspecialty care they can provide for kids, procedural support they can provide for kids. And really, the national hospitals in a lot of countries are just fantastic, training environments. But I think a lot of the kids still being taken care of at the regional and district level hospitals don't have the access to that kind of very high level of care. So I think really kind of bridging that gap is key. And I think that's a great role for academic global health to have that. And it's not a unique problem in developing countries. It exists here in the US too. So even in the US, most kids in the ER get their care at a general ER from a non-pediatric ER doc. So we similarly have that issue in the US that we try to address, like outreach kind of training.
One final question. I ask this of everybody on this podcast. What advice do you have for young people who are just now embarking or wanting to embark or thinking to embark on a career in global health?
Yeah, so I have a couple of mentees that are medical students and residents, and it's obviously, right, like the elephant in the room, it's becoming harder. And so what I'm trying to communicate to them is that despite current difficulties in funding, et cetera, kind of cultivating a global mindset and like trying to understand health inequities, which exist here, right, in the US, being open-minded to learning different perspective, trying to stay informed and adaptable. And then I think just ensuring that as a trainee, you can have the best skill set possible, whether that's clinical, analytical, research, because that's what we'll need to solve these bigger problems. And then lastly, I think Colleen and I really highlighted that there's different entry points into global health and pediatric global health. And that mentorship, at least for me personally, was really key. So identify a mentor that has a great track record, that you like working with, that, you gel with, is really paramount to developing that career.
As cheesy as it sounds, I would say, find your joy in medicine. Like, the field of medicine in general and pediatric medicine is an incredibly joyful and rewarding field. And global health is incredibly joyful and rewarding. Be open to opportunities and be persistent. I always tell folks, I've had plenty of grants get rejected. I've had plenty of projects fail again and again over time. And it can feel really disheartening in the moment. But if you really care about it and you have the kind of joy and passion behind it, you will find the kind of right thing to stick for you. And then what I always advise trainees is kind of figure out the niche you may want to create for yourself. You don't have to know exactly. And then be open to maybe atypical opportunities to support it. So if you want to get better at global health research, maybe actually doing a research project with a data set in the US will help flex those muscles and build those skills. Like Sarah said, have that really deep skill set that you can then bring to global health, engage with different projects, but be open to them and stick with it. It's worth it.
Well, it's great advice from the both of you, and I thank you very much. Thank you, Dr. Sahera Fargo and Dr. Colleen Fant, for joining me today and sharing your remarkable stories with us. Thank you so much.
Thanks for having us.
Thank you for having us.
Follow us on Apple Podcasts or wherever you listen to podcasts to hear the latest episodes, and join our community that is dedicated to making a lasting positive impact on global health.